This is Bridget Keene reporting for Circulation. Joining me today is Dr. Daniel J. Friedman of Duke University Medical Center. Dr. Friedman and his colleagues recently did the largest study to date on the relationship between prolonged PR intervals and outcomes in patients receiving cardiac resynchronization therapy. Thank you for joining me today, Dr. Friedman.
Thank you for having me.
Why did you decide to do the study, Dr. Friedman?
Understanding the optimal use of CRT has been a major challenge over the last 20 years since CRT started to become mainstream. It's been widely known that certain subsets of patients tend to not do so well with CRT, yet other subsets tend to do very well. A very commonly described subgroup that tends to do quite well with CRT are patients with a left bundle branch block on the ECG. We got interested in this specific question because there are actually a number of conflicting reports as to the influence of PR interval on outcomes among CRT recipients. Some studies suggested that a long PR interval was associated with improved outcomes, and maybe those patients had even more to gain from CRT compared to patients with a shorter PR interval. However, many studies, interestingly, suggest that, in fact, perhaps the opposite may be true, and patients with a longer PR interval may be at higher risk for not responding to CRT and doing poorly after the device implant. So we became interested in this question and hoped to be able to study it in the real-world setting, because many of those initial studies that I had mentioned were secondary analyses of randomized trials.
What did you learn about CRT-eligible patients who have longer PR intervals?
So a number of things. So first, we learned that 15% of all CRT-eligible patients have a PR interval of 230 milliseconds or longer. And so it's a substantial minority. We noted that these patients had a much higher comorbidity burden compared to patients who had a shorter PR interval. So higher rates of ischemic heart disease, chronic kidney disease, atrial fibrillation. And they also had many factors associated with differential response to CRT, including a higher proportion of men had a longer PR interval. Long PR patients tended to be less likely to have a left bundle branch block, and a few other predictors of non-response. So we found that this was a sicker overall cohort of patients.
What did you learn about the comparative effectiveness of CRT with a defibrillator versus an ICD?
We started by looking at the overall cohort, and we divided the cohort based on a long PR interval of greater than 230 milliseconds or a PR interval of less than 230 milliseconds. And we performed an inverse probability weighted comparative effectiveness analysis, first of the overall cohort, and then of the cohorts divided by PR interval. And what we found, consistent with other comparative effectiveness studies, is that among the entire cohort, CRT-D was associated with a significant reduction in heart failure, hospitalization, or death. However, when we subdivided the population by PR interval, we found that CRT-D was associated with a significant reduction in heart failure, hospitalization, or death only among the patients with a PR interval of less than 230 milliseconds. We further subdivided that population by QRS morphology. And as we had talked about earlier, that left bundle branch block finding in the EKG tended to identify patients who tend to do quite well with CRT. And interestingly, we found that even among left bundle branch block patients with a long PR interval, CRT-D use compared to ICD use was not associated with a reduction in heart failure, hospitalization, or death. So to say it another way, even patients who by common standards would be very likely to do well with CRT, we didn't actually observe improved outcomes in this study.
Why do you think you found longer PR intervals were associated with worse outcomes among the patients who received CRT with a defibrillator?
Well, that's a great question, and it's one that we're not able to answer conclusively with this study. There are a number of reasonable hypotheses. So first, as we started off discussing, patients with a long PR tend to have a higher comorbidity burden, and they tend to have many more factors associated with poor outcomes after CRT. And so it's possible that even before the device is implanted and programmed, these patients are just less likely to do well. They may just have a ventricular substrate that is less amenable to resynchronization. And that's likely a contributing factor. Now, the other intriguing possibility is that patients with a prolonged PR interval may have, at least some of these patients, abnormalities in intra and interatrial conduction as well as atrioventricular conduction that may necessitate specialized AV programming. Now, when you look at AV programming strategies over the last many years, people have trended towards programming shorter AV delays, and that's based on a number of studies that have showed across the population level, and in many studies, patients tended to do better with the shorter AV delays. However, patients with a prolonged PR interval may actually require longer AV delays because in many situations, a prolonged PR interval may be an adaptive response to delayed atrial emptying during atrial systole. And so if we were to program the usual short AV delay in a patient with a prolonged PR interval, we may be inadvertently truncating the A wave on the echocardiogram. So we may actually be causing the ventricle to contract before the atrium has finished contracting and the ventricular is finished filling. And so we may actually be doing some harm by not tailoring our AV delay program approach to these patients. However, our study does not address that, and we unfortunately didn't have any AV delay programming data available. So that's entirely a hypothesis, but it's a reasonable one and should be a focus of further research.
Do you think your study resolves some of the conflicting evidence to date?
Well, I think what our study does show is that in a real-world population of patients, CRT with defibrillator is not associated with improved outcomes among long PR patients when compared to an ICD alone. Our study is unable to tell us why this is the case, but I think it very importantly underscores that the long PR patient subset is a significant minority who does poorly, and as such, it needs to be a particular focus when we're taking care of patients and when we're thinking about future studies on how to optimize CRT response.
Do you think there's a takeaway for clinicians?
So I think the one takeaway that clinicians can unequivocally take away is the fact that long PR patients are a high-risk subset of CRT patients. And although our study doesn't tell us how we should differentially take care of these patients, clinicians should be aware of the fact that these patients are more likely to do poorly after CRT implant. They may require closer follow-up, and consideration should be given for individualized AV delay programming.
Well, thank you for joining me today, Dr. Friedman. This has been Bridget Keene for Circulation.